Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Robert Wood Johnson Foundation on engaging managed care organizations. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be 2 moderated question and answer sessions during today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Sana Hashim, Program Officer at the Center for Healthcare Strategies.
Great. Thank you, Travis. Next slide. Great. Good afternoon, everyone, and welcome to today's CDC 618 Initiative webinar made possible by the Robert Wood Johnson Foundation. My name is Sana Hashim. I'm a Program Officer with CHCS, and I'll be moderating today's webinar. This session is focused on engaging Medicaid managed care organizations in the adoption of 618 interventions and will feature presentations from North Carolina and Minnesota. Most states in the 618 initiative have a significant number of Medicaid lives under Medicaid managed care. In the absence of specific state and federal regulations, coverage of particular services and the determination of whether there are copays or limitations on the benefit are up to the discretion of individual MCOs. Because of this, MCOs are important partners to work with in implementing the interventions. The 618 states are well on their way to engaging with their MCO partners. Many states, like Minnesota, have administered MCO surveys to better understand the specific benefits that MCOs provide, and others, like North Carolina, are operationalizing procurement strategies to partner for more effective uptake of the 618 interventions. Resources like samples of MCO surveys and other MCO engagement tools can be found on the 618 Resource Center website. Today's webinar will offer strategies to enhance and align prevention benefits across Medicaid health plans, describe opportunities to leverage MCOs for member and provider outreach, and provide a forum for sharing lessons about how to effectively communicate with MCOs. Next slide. And one more. So I will start us off with some brief background on the topic, including benefits and considerations around MCO engagement. We will then hear from the North Carolina 618 team, Kelly Crosby, Deputy Director of Quality and Population Health with North Carolina Medicaid, Sally Herndon, Head of the Tobacco Prevention and Control Branch at the North Carolina Department of Health, and Joyce Sletlick, Director of Tobacco Cessation at the North Carolina Department of Health, on how they incorporated 618 prevention priorities into MCO procurement. And finally, we'll hear from Laura Olivan, Tobacco Control Program Manager with the Minnesota Department of Health, who will share that state's efforts to survey MCOs that ultimately informed the standardization of cessation coverage. Next slide, and one more. So I'll now provide a brief introductory background on the topic before turning it over to the states. So in the process of working with their MCOs, states will find several benefits. Partnering with managed care around prevention priorities allows states the opportunity to build and sustain solution-driven partnerships. One successful project can lead to another, and with the right contacts and champions, that relationship can be long and fruitful. Partnering with MCOs also enables access and outreach to both providers and members alike through established communication channels. And considerations to partnering may include the contractual process, including contractual obligations, limitations, and amendments, as well as having to coordinate with the implementation of the state plan. The need to create buy-in for prioritizing prevention may also require states to strategically and thoughtfully approach new MCO partners. So at this point, I will turn it over to the North Carolina team to share their approach to engaging that state's MCOs. So Kelly, Sally, and Joyce, the floor is yours.
Hey there, this is Kelly Crosby. As Sana said, I'm the Deputy Director for Quality and Population Health at the Division of Health Benefits. That's our North Carolina Medicaid program. If you go to the next slide. We are in the middle of, as some of you know, we're in the middle of actually implementing our statewide managed care program. Over the past 2 years, we had the pleasure of working with Sally, Joyce, other colleagues at Public Health on the 618 initiatives. And it was at a really pivotal time for us when we were developing our RFP for health plans and developing our quality strategy and what our clinical and population health priorities would be for the program. So what I'm sharing with you right now on this slide is our managed care quality framework. You can see it shows our aims, goals, and objectives, but I have places where I have starred directly how 618 factored into our work. Under our promoting women's health objective, we are looking at pregnancy and tenderness as one of our priority areas. We're looking at diabetes management and prevention. We're looking at asthma management, and we're looking at addressing tobacco use, both prevention and cessation. So we were able to, these are priorities for us as a North Carolina Medicaid program, and of course, they align with 618 priority areas. So they are built right into our quality strategy. Next slide, please. This slide just shows how we have mapped different interventions that we're engaging in Medicaid to our different quality aims, goals, and objectives. And you'll see right there, again, I have a star, that we built 618 right into our initial development and design of the quality strategy. And you'll see later how this feeds into actual operational programs that we require of our managed care organizations. Next slide. So again, our quality strategy objectives are to improve diabetes management, improve asthma management, address tobacco use, and promote women's health. That's obviously broader than pregnancy and tenderness, but clearly that is an objective under promoting women's health for us. For us, like most states, we try to use standardized measurement to align with the CMS core set, NQF, and CQA. So we were able to pull particular measures that were associated with these areas and make them priority measures for our health plans. Obviously, they're measures so they don't line up perfectly with preventing diabetes, as an example, but these are important measurements so we can actually track the trajectory of the disease and standard of care for these different 618 priorities. So these are our particular performance measures that were specifically pulled in for alignment with 618. What you don't see on here is all the other information that we're collecting around diabetes prevention work, use of things like the quit line, but these are the standardized measures that we're using to track 618 performance. Okay, if you go to the next slide, we've also woven the 618 priorities into the required clinical performance improvement projects that health plans have to do. So that is our total list of year one performance improvement projects. And as you can see, pregnancy and tenderness, tobacco cessation, and diabetes prevention are all right there. Those were the three that North Carolina picked. I guess I'm saying that like y'all know that. Those are the three areas that we picked to focus on for 618. We've already begun work with the health plans around introducing them to the North Carolina tobacco cessation programs that Sally and Joyce manage here. And our work in these three areas is to work collaboratively with our partners at Public Health to develop statewide standard performance improvement projects in these areas to increase uptake of evidence-based programs and to align the resources of Medicaid and the resources of our MCOs with the public health programs in these areas. Next slide, please. We also decided that we wanted to share information and data back with our MCOs. So we're using BRFIS data actually that our colleagues at Public Health capture specific to folks on Medicaid to share back with our health plans. As they develop their quality assessment and performance improvement projects, we wanted to give them data about Medicaid folks who are smoking, using tobacco, smoking during pregnancy. So a lot of the data that we're collecting from other public sources that you can't get through Medicaid claims, we wanted to share back with the health plans so they could use this information in their planning for performance improvement projects. A big thing that we did was requiring all the our managed care organizations, there are 5 of them, we call them prepaid health plans, they're required to contract with the statewide quit line. So there is one evidence-based care quit line in the state. Beneficiaries have one line to call. We have a standard benefit, and all health plans are feeding into this. And we are able, as well as our public health colleagues, to get a whole lot of data from the quit line here in North Carolina. So that's just a broad overview. I'm going to hand the mic over to Sally, but that's a broad overview of how we really try to focus improvement efforts, measurement and improvement in our 3 areas from the 618 initiative. And so this is something that was just embedded in our managed care program and will go forward. So Sally, let me turn that over to you now.
Sally, if you're speaking, we can't hear you just yet. You might be on mute.
Yes. Can you hear me now?
Yes, we can.
Oh, great. Thanks. Thanks, Kelly. We are sure grateful for the 618 project and our partnership with the North Carolina Division of Health Benefits. As you all know, we know a lot about what works in tobacco control, and we know that it's not just one of these elements that you see on our tobacco control vaccine on the screen, but it's really a strategic and synergistic combination of media policy and program services that really help us reduce the health and economic burdens of tobacco use in North Carolina and the nation. Next slide. So in North Carolina and the nation, and if you'll click one more time, please, tobacco users really struggle with an uphill battle. With 618, we're primarily concentrating on the aspect that has to do with poor access to cessation help and removing those barriers to tobacco users who want to quit, which, by the way, are a majority of tobacco users in North Carolina as well as nationwide. And if you go to the next slide, we can talk a little bit about our 3 major goals that we were working on and still are working on. First, to promote health systems change, to expand insurance coverage and utilization of proven tobacco treatment in order to increase access to evidence-based tobacco treatment. These are our areas that we focus on. And we're very proud of our quitline NC in North Carolina and really wanted all North Carolinians to have the benefit of these evidence-based services. So this partnership is making that opportunity more robust and more available to Medicaid populations in our state. Next slide. All the while in North Carolina, we in the Tobacco Prevention and Control Branch are really promoting tobacco treatment standard of care. We know so much about what works in tobacco treatment. It's really a combination of evidence-based counseling, and the more you do counseling, the better. The higher dose gets the better response, and that has to be combined with FDA-approved pharmacotherapy. And what we find in terms of looking at the research for the pharmacotherapy is that what is specifically most effective now, according to the research, is 12 weeks of varenicline or 12 weeks of combination therapy, nicotine patches for the long-term addiction and nicotine gum or lozenge for those breakthrough cravings. In fact, there was a Cochrane report recently submitted on the value of combination therapy for tobacco users who want to quit. And so we focus on those kinds of things as the things we want most people to have access to. Next slide, please. And in 618, we have a fairly robust offering from Medicaid for tobacco treatment. But we really wanted to dig down a little bit deeper and work with our colleagues as we transition to Medicaid managed care to see what kinds of things we might be able to add and what kinds of barriers we could take away from tobacco users who are trying to quit. Next slide, please. And so the major things that we were able to accomplish through the 618 process was first an incredible collaboration with, there's a typo here, there are 5 North Carolina prepaid health plans who are all using the same quitline vendor as our statewide quitline NC in North Carolina. So they're consistent quality services that everybody who is a tobacco user who wants to quit and wants to use the quitline is getting across the state. And then, as was said earlier, this is a really important data source for us, and we are sharing population data back and forth to really track our progress in population health. Something also that we created to reduce the barriers for tobacco treatment is really understanding down at the clinic level what the barriers are for the CMS requirement that you have to have a prescription in order to get over-the-counter nicotine replacement therapy. And we're just about to launch a creative strategy in North Carolina that I believe is available in many other states if you'd like to follow our lead. By providing a standing order from a North Carolina public health physician who's licensed to practice here, who provides a standing order through our quit line, so that when the Division of Public Health with our state funds for quit line provide a 2-week starter kit for Medicaid eligibles, they are mailed the standing order, don't have to go to the doctor, don't have to take off time work, but can just go ahead and get the 12 weeks of nicotine replacement therapy through their Medicaid-approved pharmacy. This really reduces that burden of prescription that's required for administrative purposes. We also have added a standing order to our local health departments, and they will be able to provide nicotine replacement therapy to patients that they are seeing in clinic to reduce that same burden. So those are our big 2 outcomes out of the 618 process. But as was said earlier, our collaboration with the Division of Health Benefits is continuing. And if you go to the next slide, as Division of Health Benefits begins to work on collaborations to address the tobacco treatment disparities in the behavioral health communities in North Carolina, and works more to begin to integrate traditional Medicaid in with medical and behavioral health care. We'll be looking to work collaboratively to have behavioral health clinics go 100% tobacco-free, while at the same time working to treat tobacco addiction concurrently for people with mental health and substance use disorders. Our quit line is also very impressed with a new behavioral health protocol that's been tested out in a number of states. And our new behavioral health protocol will launch sometime in May or possibly June. Now we've had maybe a little bit of pushback because of the success of the Tips for Former Smokers campaign at CDC is using, so we may have to push it back to June, but we're excited about the opportunity to do that. Next slide, please. I'd also like to share for those of you around the nation, if you're interested in a really high quality certified tobacco treatment specialist training, come join us in North Carolina. We have a Duke UNC collaborative. It's nationally accredited. We offer this training. It's a 4-day, very intensive training that qualifies people who attend the session to become certified as a tobacco treatment specialist. We offer this program 3 times a year, and we move around the state to make sure that all the health systems in North Carolina have easy access to this excellent training program. So if you go to the last slide, I just want to thank everybody and click one more time. I'd like to thank everybody in 618 for helping make the plight of tobacco users a little bit more of a downhill battle by eliminating barriers and making easy access to tobacco treatment possible in North Carolina. Thanks so much.
Great. Thank you so much, Kelly, Sally, and Joyce. That was a really fantastic presentation, a lot of great information. So at this point, we'll open up for a few questions. And again, like Travis mentioned, you can submit those questions right on the Zoom platform through the Q&A feature. So if folks want to go ahead and start submitting questions, we'll go ahead and pose them to our speakers. So one question for you all, for Kelly, Sally, and Joyce. What major challenges have you all faced in trying to engage or partner with the MCOs in your state? And if you can offer some strategies for working through those challenges.
This is Kelly. You know, that's a hard, sorry, stumbling, because that's a tricky question, because we're right in the middle of implementation right now. And we've had our initial onboarding session with the PHPs. They met our quitline vendor. They met Sally and Joyce, and Sally and Joyce were able to give them an overview of all that's happening in North Carolina. And they were met with enthusiasm. So, and they're all contracting with our quitline vendor, and so far so good. And I think it, you know, truthfully, like part of it is we are lining on priority clinical conditions for Medicaid populations. I mean, it's hard for them to disagree and on these should be priorities for us, and any way we can align is good. I think, you know, a lot of them have, you know, historically maybe their own quit line. A lot of the things that we're asking them to measure, they would measure anyway by virtue of their accreditation. So, you know, I don't know, Sally and Joyce, how you felt, but I was very pleased with the reception that you guys got from the health plans. I feel like because, like you'll notice that one of the things that a thornier issue, which is NRT, for us, it's not thorny so much because of the health plans, but our benefit, our pharmacy benefit, our PDL is very scripted currently still by us at the state. So I think, you know, and Joyce and Sally are more expert at this than I. I know we have a decent NRT benefit, but there are some barriers that we need to work through. And if ever we kind of turn the pharmacy benefit over to the health plans, that might be a thornier conversation. I'm not sure. But in terms of good patient engagement around evidence-based practices, I mean, I think it's what we expected. We expected the MCOs to be happy. I think it's helpful, though, that we are doing this out of the gate, right? So they didn't have time to implement their own cessation programs or their own quit lines. And so we're not asking them to dismantle anything. We're asking them to implement from the beginning. And I'm sure that's kind of helping. We're not asking them to change any current business practices.
Yes, I agree. This is Sally, and I think the advantage of the timeliness of 618 as we were creating this new system of moving to managed care, Medicaid managed care, was excellent for us. And I echo the same benefits of what we've been doing together that Kelly echoes. And in terms of barriers with this, ask us again another year, and we'll talk to you about what the process has been like this first year. I'm really excited about the standing order. I think that could be an opportunity for other states to follow our lead. And if folks are interested in talking more about the logistics of that, Joyce and I are happy to talk with other folks. We did check in with ASTO to find out if there was a legal basis for this in many states, and there is. So with that, our quitline vendor was willing to move forward and work on this strategy with us of providing a standing order.
Great. Thank you both. And just a reminder to folks, as you're listening to the presentations, you can always submit questions even during the presentations in the Q&A box, and we'll certainly get to them. So at this point, we will go ahead and open the floor to Laura Olivan from Minnesota to discuss how Minnesota's surveying of MCOs informed the standardization of tobacco cessation coverage. So Laura, the floor is yours.
Thanks, Sana. This is Laura Olivan. I'm the Tobacco Control Manager here in the state of Minnesota, and I was part of Cohort 1 of the 618, and we just focused on tobacco as our strategy area. And I'm sorry that Ellie Garrett, my Medicaid counterpart, could not be on the call today. Mine is not as dramatic a story as North Carolina, but it's kind of a practical story of implementing these strategies and how you can take care to look to see the scope and depth of the benefits. So next slide, please. Just as a quick background, here in Minnesota in 2017, Blue Cross Blue Shield did an analysis of our healthcare costs and found that we're spending over $3 billion in excess healthcare costs related to tobacco. Like many, we have quite a few deaths associated, and our Medicaid costs are considerable annually as they relate to tobacco. So we have plenty of incentive to pay attention to this. Next slide, please. In addition, we've recently reached a historic low in our overall tobacco use rates among our adults here in Minnesota. But when we looked at our BRFIS rates for Medicaid enrollees, we found it was twice that rate. So we thought it's part of what motivated us to participate in the 618. And for those of you who've never been on the CMS website, and they're a partner to CDC on this, I love the fact that on the, at least before when I was in this, on the front page of their landing page for Medicaid, they reference the fact that cigarette smoking is one of the greatest drivers of healthcare outcomes, and it's one of the most effective preventative services. So if you don't have your own incentive and rationale, CMS is right there with you to provide one. Next slide, please. So here in Minnesota in 2016, well, let me back up. We've been working for several years on a policy change related to cessation benefits. And with the passage of the ACA and the policy change that required free preventive services, ARB, it enabled us to make the case for a policy change in Medicaid. So in January 1st, 2016, a new law went into effect here, waiving copays in Medicaid for consistency with the ACA for preventive services, which included NRT and prescription medications like Chantix. I think we were the first state to be declared barrier-free for our Medicaid cessation benefit, meaning no pre-authorizations and no copays. So it meant free access to cessation benefits. So having achieved that, and it's all 7 FDA cessation medications, that was a really big deal for us. But we also know, and I think this can vary in states, is that there is variation across MCOs, managed care organizations, kind of in the depth and breadth, kind of the scope of medications and services. So we wanted to find that out because when we did a lot of work in the last 2 years in the public housing authorities, and first, many residents don't even know they have access to Medicaid benefits. But after that, we hear common stories that, oh, they said we could only get 2 weeks, or oh, it's capped, or I don't think they include Chantix. Well, we wanted to be able to document the extent to which these benefits were available. Next slide, please. Now, I will tell you that over the years, I had tried different ways and used different partners to try and get this information. And it wasn't until we participated in the 618 that I really formed a true partnership with Medicaid over at Department of Human Services. And it was during this process that we asked Medicaid to do this survey because we really had not gotten very good information on our own. So obviously your DHS has that relationship, in fact, a contractual relationship with the MCOs. If for any reason you find that they're not adhering to the law, it's DHS that would be in the position to ask them to modify their benefit scope. And frankly, it enhanced awareness of tobacco cessation in our Medicaid program and had them looking at the scope of tobacco-related benefits and services. Next slide, please. So at a high level, we really wanted to look to make sure that our beneficiaries, that the enrollees did indeed have access to the 7 FDA. We were double checking that it was barrier-free. We were really most interested to find out how much benefit the enrollees were getting. And we also thought to add a question related to the extent to which they promote the benefit for tobacco. So those were kind of our high-level approaches, what we were looking for. Next slide, please. Then we broke it down to these categories. I thought it would be worthwhile. And I am willing to share the survey. I'm pretty sure Sana has it because there's a lot of technicality that you have to think through in the survey. But we broke it down so we'd be able to gauge the telephone counseling. We separated the NRT types and durations with the prescription medications. We did our double check not only on pre-authorization, but any other kind of requirements, maybe a prerequisite that they do counseling before they can get prescriptions. And then again, on their level of promotion. Next slide, please. So our findings, and I do have a one-page write-up of our findings, which I think Sana has too. And we were really pleased with the outcome. So 6 of our 9 MCOs covered telephone counseling. They don't contract. They provide, these are long-standing MCOs, and 85% of our Medicaid program is MCO-driven. So we have a very unique situation where they run their own counseling and then we coordinate it. Most had in-person counseling. This was actually, the next one was probably the biggest finding, is that 7 of our 9 do not even limit the number of days of supplies of NRT. So keep in mind, contrast that with a quit line where we provide 2 weeks of NRT up to twice a year. No, excuse me, 4 weeks. If you register with the whole program, then it's 4 weeks, 2 times a year. But 7 of our 9 didn't place any limits on NRT. And 7 out of 9 didn't place any limits on prescription medications, of course, as long as they're medically justifiable. And 8 of 9 had no prior authorizations or any cessation medications. Next slide, please. One other benefit is that, oh wait, actually, let me just tell you about the promotion. One of the surprises of the survey was that we found that the MCOs do very little promotion of their tobacco cessation. Everybody has it on their basic welcome packet, and I don't even think the MCOs are mailing. I think in some cases it's just electronic. So it's one of the many benefits that are included for the enrollee. 1 or 2 maybe included the information on tobacco cessation and newsletters. And 2 were actually working in a more meaningful way to integrate tobacco cessation into their health system effort. So if you did mailings or any kind of higher level promotion, which if you think about it is a little surprising given the health and cost consequences. But in this respect, I suppose we're competing with every other chronic disease or behavior-related issue. Next slide, please. One other thing I wanted to say about having the Medicaid program doing the survey, in a few instances, we did find out they were out of compliance. So the the Medicaid program was in the position contractually to enforce adherence to the new law that had passed in 2016. But I think one of the biggest benefits is our kind of ability to be able to say with confidence that by and large enrollees will have what they medically need to quit from their Medicaid program. So as we go out there and not only promote the quit line, but really urge, and we have a whole campaign, which we can talk about another day, urging people to go to their doctor for help quitting, that we have really a high degree of confidence that the MCO will be able to provide to the enrollee what they medically need to quit, and that we can send them with confidence to their doctor. Next slide, please. And Sally kind of reinforced this, but just if you take a look, and they're really rather old, but it's still what is the federal government guidelines called the Clinical Practice Guidelines. If we leave smokers to their own devices, they really have a very little chance of quitting. But if we can connect them, whether it be the quit line, frankly, or through their doctor, to help with counseling, over-the-counter medication, prescription medication, and ideally combinations of not only medications, but counseling and medication, you can see we can practically triple the rate of success, which is the real goal here. So that is the end of my very brief story, and I hope that you found that useful. Thank you.
Great, thank you so much, Laura. I think both states have been doing fantastic work, and it's great to hear it, and we're happy to host this. So we will open up for questions at this point. So again, you can use the Q&A feature on the Zoom platform to submit any questions that you have for the speakers. So one question for Laura, what communication strategies have you found especially effective when working to engage with the MCOs in your state? So for example, were face-to-face meetings more effective, and were there certain contacts that you reached out to, just sort of around the best way to reach out to MCOs?
Well, after we completed this process, and we actually also did an all-payer claims database evaluation, which, again, we can talk about a different day, where we found out the extent to which physicians or healthcare providers were actually writing prescriptions. Once we got those benefits available to people, we contacted very often the medical directors, sometimes other avenues depending upon the connections, and are still actually in the process of doing individual presentations to them. Now, having said that, fast forward 2 years, a recent phenomena is I have just recently completed arranging for 3 presentations to health systems as opposed to plans that really want to hear from us on youth e-cig use. So that's now, interestingly, where I was kind of having trouble getting in to see the plans, now the systems are calling us as a source of information on the youth e-cig epidemic. So there's different ways, I suppose, to get in the door, and we use every opportunity to promote all of these things.
Great, thank you. We have a question that came in. What information do you feel made the strongest impressions during your initial talks with the MCOs? And this is for either state.
This is Sally. From North Carolina, with the onboarding presentations that we did to our new PHPs, I will echo what Laura just said. We had a fortunate occurrence on our onboarding day, and the speaker who was supposed to speak ahead of me was out of town, and Kelly said, "Gee, Sally, tobacco's important. Why don't you take a little bit more time?" So we stepped back and talked really not just about tobacco treatment and tobacco cessation, but about the state of tobacco prevention and control in North Carolina. And there was so much interest on the part of the of the new managed care plans, the prepaid health plans, on youth initiation and the e-cigarette epidemic, both from professional point of view and in some cases from a parental point of view. So it led to very good discussions, and I think will lead to continued work together in both preventing and reducing tobacco use and helping tobacco users quit.
I would say the cost and the ROI information is impactful. The extent the smoking rates amongst Medicaid enrollees is impactful. And then most recently, there is interest in this all-payer claims database. I don't know the extent to which MCOs are analyzing what happens when enrollees that smoke come into the office and the extent to which they are being referred. That's nice to see in North Carolina that you are using the quality standards. Those are recommended by the feds. They don't necessarily use those here, and I think that's very smart because it can come as a surprise to find out that whereas almost everybody's screened, do you smoke, really a relatively smaller percentage of people are actually referred or the script is written. And also in North Carolina, kudos to you to have a standing order. You have to make it easy. So I think all those things are compelling. I think data and dollars probably have the biggest impact on plans.
This is Sally. Just to echo that, I was at a conference, a legal conference with the North Carolina Association of Local Health Directors, and there was a presenter who had helped transition Oregon to Medicaid managed care, and he was very clear that the two areas where there was the best cost savings were immunizations and tobacco treatment.
That's great. Thank you both. So another question, what role do you see Medicaid health plans playing in this work? Do you see them as a key partner or more in a supporting sort of secondary role? And do you see their role changing in the future?
This is Kelly. I definitely see them as a key partner. I think really where we've focused on performance improvement is measurement and performance improvement is because we really think, I'm going to say something really obvious, we set the policy agenda, we set the guidelines for what we're going to measure, but really they are in the field affecting change with providers. They've got the tools to try to help individuals make better choices or have options for choices, and they're there to help providers and train providers. They're just I see them as a really valuable partner. And truthfully, I think one of the upsides for us is the health plan's ability to bring innovation and new ideas that we haven't thought of before. So I think it just opens up a whole array of tools and opportunities for us. I do think it's critical that we set the policy agenda, we set up the right incentives in our health plan ourselves with our contracts with the health plans, so they understand what is important to us and what our expectations are. But in terms of being able to innovate and really enact change, pay for things we wouldn't typically pay for, be able to do things with beneficiaries in new ways, I consider them incredibly valuable partners.
From the public health perspective, I 100% agree. And that I've always thought that public health and healthcare need each other. We each serve a role, and we can enhance perhaps and amplify the work of each other. We also have the kind of strength and breadth by having community-based organization grantees that can, especially in our state, we have funded groups that are the most disparately impacted. Now here I focus on groups for tobacco purposes, but many of those populations also carry the disparities in other chronic disease areas. And we can engage those populations and help bring them into their provider offices for care management or treatment or what have you. So I do think we make each other better. I have an open door policy and am constantly trying to engage the plans because, as I said, we really can't do it alone.
I think both of those answers were well stated. This is Sally, and I'll give an example of that, of something else that I'm working on that may be something that Kelly and I can work on later, and that is, as Laura said, we've also been working closely with public housing and affordable housing to help take those facilities tobacco-free, to eliminate exposure to secondhand smoke, and to help tobacco users quit. And as we look at our asthma data in North Carolina, we find that kids with asthma are much more likely to be out of control and in the emergency room or in the hospital if their triggers at home are not well controlled, which include secondhand smoke, and that's where I come in, and an array of other triggers to asthma like mold and mildew and so forth. So the public health partnership with the Medicaid managed care communities and the providers can really affect cost-saving change if a child who has asthma that's under poor control can refer to a practitioner who can assess the asthma triggers in the home and help the family and perhaps the landlord make those changes. And we're finding it a benefit to really take multi-unit housing tobacco-free, and it shows really good data in terms of reduced cost per patient and reduced ED visits and reduced hospitalizations.
Great, thank you all. So the next question is that since each MCO is a distinct entity with their own marketing campaigns and member manuals, how do you ensure that all Medicaid recipients know about available NRT or other covered services?
I can answer that one to start. So I had hoped that either the MCOs would more broadly promote tobacco cessation, or that DHS would do a mailing. And actually, neither one of those happened. Well, the MCOs are each working on it, as Nashon points out. DHS doesn't really do mailings to enrollees, so beyond like promotional mailings. And we had offered to pay for it, but that's not really something that they do or think is cost beneficial. So in the end, we actually used our CDC ensuring quitline capacity funding, since I don't run a quitline, at least right now, and they have been running a statewide Medicaid promotion campaign for NRT. And the other thing is we have very, very broadly engaged and partnered with our grantees. Both, we have 41 local public health grantees that work in the community, and our 11 community-based organization grantees and our 10 tribal grantees, to make sure that they are aware that Medicaid will cover those costs. And I think that we are making some progress. That's why we did that APCD analysis to see whether we've indeed had an impact, and there are more prescriptions and referrals made for tobacco cessation medication.
Great, thank you, Laura. So we have one question that's specific to diabetes self-management education, and it's around suggestions for working with MCOs to encourage referrals to accredited or recognized diabetes self-management education and support programs. So any insights there just around encouraging referrals to diabetes self-management programs or referrals to tobacco cessation?
I'll just share this. This is Kelly Crosby on the North Carolina Medicaid side. One of the things that we wanted to do was explore the idea of covering diabetes prevention program as a Medicaid covered benefit. And just because of the timing for us, it just was not a good time to update a state plan services. We were trying to do an RFP for managed care. But one of the things we committed to was to work with the plans for diabetes prevention, other diabetes self-management programs as value add. We asked them to work on member prevention programs that should align with their performance improvement projects. Again, that's how we're linking back diabetes prevention as a priority area for us. Part of what we'll work with our public health colleagues on is just letting them know the resources that do exist in North Carolina for DPP and other services. But I think a lot of them already are, since diabetes obviously is a huge problem for Medicaid and pre-diabetes, that's something that they want to do anyway. And so I think again, we set the policy standard for them. We set the priorities for them. And I think part of our task then really is to help them track to evidence-based programs, help us understand. We've asked them to describe how they identify individuals for those programs, how they incentivize members to engage in those programs, how they incentivize physicians to refer to those programs, and how they track outcomes of those programs. So, again, we kind of set the policy standards that diabetes prevention and management and member incentives, as well as member engagement programs, really matter to us, and show us how you're going to refer, measure, educate around that. But again, that one was not, that was pretty standard for our plans. So now it's for us to help them align on things that get good return on investment and are based on evidence-based care.
Great. Thank you, Kelly. So we have a question that came in. Can you talk about the PMPM per member per month rate development as it relates to tobacco cessation, and any advice on calculating and negotiating? So perhaps this is for Kelly.
That was a really interesting one. We have our draft rates out, and we're working on finalizing our PMPM rates right now. The truth is that the quitline benefit is really, really cheap. There's probably a better term, cost effective. It just does not, it adds pennies to the capitation payment. And to be honest, the biggest struggle we're having right now is, like most Medicaid programs, the vast majority of our beneficiaries, over 60%, are children. And so it's trying to help balance the PMPM rate to account for that, if you will, because we've got to chunk up the rate across 5 health plans, and there might be not necessarily the best distribution of children to adults across all the plans. We're going to try that. But there really is, it was pennies in the capitation rate, and we committed to it as a covered benefit that we were paying for in a certain way through fee-for-service currently. And the good thing too, I would say too, is because we're using a standard vendor that probably a lot of states use and a lot of health plans use. They have a going PMPM that they charge health plans, and they were able to tell us what that was, and we were able to talk about their methodology and just absorb it into our capitation rate.
Great. Thank you, Kelly. So a question about patient engagement and what patient engagement looked like sort of before and after your engagement of MCOs how it changed, and any pushback or any challenges that you experienced around engaging members. This question is for any of the speakers.
I think for North Carolina, that's a little too early to tell.
Yeah, I agree. I don't think we know. I think one of the things, though, that again, I feel like we have a tool. Hopefully the
tool will work, but first we intend to align the PHP's marketing materials for the cessation line in particular with the current public health. So we're hoping to double down on marketing. But also, I don't know, I feel like we have a valuable tool. Again, we have different ways through managed care to incent members to really engage in some of these programs that we don't necessarily have through Medicaid. I can't speak to the resources that my public health colleagues might have, but we're fairly limited in Medicaid. But I think we will have more tools at our disposal in managed care to get folks really to engage.
And I think our strong engagement with our history of our quit line has been very positive and helped us sell the idea of using this one quit line. We have good statistics on customer service and very good stats in terms of usage rates and quit rates as well. So, but we'll check in with us in another year and we'll have a little bit more of a story to tell.
Great, thank you. So just keeping an eye on the clock, we have just a couple of minutes left. So we're going to wrap up our questions, but certainly if you think of any and you'd like to get them answered, feel free to send them our way, and we'll be sure to get an answer to your question. So I do want to thank all of our presenters, Kelly, Sally, Joyce, and Laura, as well as all the attendees for your thoughtful participation in our session today. And of course, thank you to the Robert Wood Johnson Foundation for its continuing support of this important work. I do want to remind everyone about the 618 Resource Center website. So it's 618resources.ch.cs.org, and it offers practical how-to resources for implementation of the 618 interventions. The Resource Center actually has dedicated sets of resources on MCO engagement specifically, so we encourage you to check those out. And for participating 618 states, state surveys and other resources are also available on the private portal. Please take a few moments after the webinar ends to complete the evaluation survey. Your responses help us develop the most effective and useful learning opportunities for you. So thank you again for joining, and have a great afternoon. Thank you.